Morning, good afternoon, and good evening to all. I hope everyone's keeping safe and maintaining good health. A very warm welcome to all the panelists and viewers who have joined us across the world. I welcome you all to the second part of Nystagmus Decoded, where we'll be focusing on the surgical management of nystagmus. Nystagmus surgery aims to reduce the amplitude of nystagmus with either improvement of visual acuity or a reduction of a bothersome head posture. Today, we have a panel of eminent surgeons who will take us through the surgical planning and nuances of surgery for managing nystagmus. I wish a very happy Teachers' Day to all the teachers as we celebrate Teachers' Day in India today. So hereon, I request Dr. Maria and my mentor, Dr. Shashikant Shetty, to introduce the panelists of today's talk. Dr. Maria, over to you.
Thank you. So I don't think any of the panelists actually need formal introduction, but so first of all is Dr. Cowell, who's a director of Strabismus at the, sorry, let me just change my screen. Director of the Strabismus service at the Royal Victorian Eye and Ear Hospital in Melbourne, which is the oldest and largest academic ophthalmology department in Australia. So his main interests include infantile nystagmus, complex strabismus, and the new radiology of strabismus. And he was honoured recently as the strabismus keynote speaker at the 3rd WS-BOSS meeting in Barcelona in 2015, and was the Cushman webinar medalist in 2017. So Dr. Serafino is chairman of the Unit of Ophthalmology at the Gianna Gislini Institute's Children's Hospital in Italy. He has a fellowship in pediatric ophthalmology from the Storm Eye Institute and an observership in pediatric anterior segment disease at the Pediatric Ophthalmology and Genetic Unit from Wills in the US. Oops, sorry, I can't change the screens. And Dr. Koktigit is an associate professor of ophthalmology at the University of Health Sciences, both at the Istanbul Beyoğlu Educational and Research Eye Hospital, where she's chief of pediatric ophthalmology and strabismus department since 1990. And this is the biggest training and research eye hospital in Turkey, as well as the new Istanbul City Training Hospital, where she's been the director of ophthalmology since March 2020. She's a member of many ophthalmology societies, including APOS, ISA, AAO, ASCRIS, ESCRIS, and the Turkish Ophthalmological Society, as well as the Greek and Turkish Republic Ophthalmological Societies. And Dr. Shetty needs the least introduction. He's one of the organisers and a colleague and good friend. He's the head of the Department of the Pediatric Ophthalmology and Strabismus unit in the Aravind eye care system in Madurai, and his special interests are eye movement recordings and nystagmus.
I'd like to introduce Dr. Alan Spielman. He's a good friend of ours and a great teacher. I had spent some time with him when I was in France. He's a French ophthalmologist specializing in the diagnosis and treatment of strabismus, nystagmus, and oculomotor palsies. His contribution include work in the field of pediatric ophthalmology and neuro-ophthalmology. He's an expert in extraocular muscle surgery. He has improved and developed innovative techniques throughout years of his practice. And I think he's well known for his no assistant strabismus surgery. And he's an administrative counselor of the International Strabismological Association. Dr. Maria, who is again a good friend of mine and a good colleague, very always helping. She's a consultant ophthalmologist at Moorfields Eye Hospital, London since 2012. She's a great pediatric ophthalmologist specializing in nystagmus and eye movement recordings. She's trained in around London in Great Ormond Street Hospital, and she runs nystagmus clinics both for adults and peds, and nystagmus and eye movements related research in Moorfields. These are our fellows who are very instrumental in kicking up this webinar. Dr. Monisha, she's a fellow in our department, and Dr. Ruthvi, she's also a fellow in our department. Thank you.
We have a pre and a post lecture poll just to see how this webinar is going to influence your practice patterns. Also, I'd like you to know it's running live on the YouTube channel, Aravind Eye Care System. So if you're unable to join us here, you can join us there, but the poll questions can be answered only through the Zoom link. So I'll be sharing the Zoom link again in the YouTube channel in case any of you haven't received it. So just before we begin, please let us know where you're participating from.
Tatlım sen oradan işaretle Avrupa'yı ve pediatrik oftalmolojiyi.
Ben buradan işaretleyemiyorum.
Ama şeyler kullanabiliyor.
And also let us know if you're a pediatric ophthalmologist, orthoptist or an optometrist, a fellow or a resident, and if you're interested in nystagmus management.
Sen hep beraber ekrandayken veya ben tek başıma ekrandayken bir al. Fotoğraf ondan sonra yardım edersin.
Yani ben şu anda bunu işaretleyemiyorum.
İyi işaretlemiyorsan kalsın. Zaten şu an katılan 35 kişi. Çok fazla değil. Bizimkiler de henüz katılamadı herhalde. Yani 35 kişinin içinde sen de varsın.
So do you think eye movement recordings is necessary before planning nystagmus surgery? Yes and no. The instrument I use to measure abnormal head posture, whether it is cervical range of motion, goniometer, torticolometer, or any other. So should abnormal head posture be considered a determining factor to plan a nystagmus surgery? So I prefer a tenotomy and reattachment procedure for nystagmus surgery, yes or no? Plan a second surgery for a residual or recurrent AHP. I wait for 3 months, 6 months, 1 year, or more than 1 year. So I'd end the poll here. So I'll share the results here. So most of them participating from Asia, and probably a lot of us here are pediatric ophthalmologists and a few resident and fellows. So many of them think that eye movement recording is necessary before performing nystagmus surgery. And most of them probably are using goniometer as a tool for measuring abnormal head posture. And they think abnormal head posture should be considered a determining factor to plan a nystagmus surgery. So we have almost equal of them telling that they prefer and not prefer a tenotomy and area attachment for a nystagmus surgery. And probably about 64% people say that they wait for at least 6 months to plan a residual or a recurrent AHP second surgery. And okay, so let's move on. So without further ado, I welcome Dr. Serafino to take us through the parameters that need to be considered before planning a patient for nystagmus surgery. Dr. Serafino, over to you. Please share your screen.
Yes, thank you. Let me share my screen. So first of all, in the meantime, let me say thank you. Let me say thank you to Shetty and his colleague for this kind invitation. Shetty is a very good friend, very good friend. So I'm really happy to participate. And he asked me to talk about the parameters to consider when you are, facing with when you're planning for nystagmus surgery, also if age matters or not, and also other parameters. So first of all, what should we consider when we have to plan surgery for nystagmus? Age, anomalous head posture, if yes or not, if it's present, if it's relevant, kind of course, the type of anomalous head posture that we will call AHP for convenience, and if there is a convergence dampening of nystagmus at near, and if strabismus is present, yes or not. This is very important when we have to figure out what kind of surgery we have to do, and also if there is an aperiodic asymmetric alternating nystagmus. So let's talk about the age first. And the first question is, should we wait for surgery? I mean, there is still some controversy about the age of surgery, but let's talk about a few things. It's important to remember why the patient is posturing. So if we make an example, of a patient that adapt to an eccentric position of gaze to see better, where their visual function is best. We should know that the eccentric null position develops at the same time as the nystagmus in infancy, and it doesn't go away. Actually, we know that all patients that have as anomalous head posture in early infancy because of nystagmus, of course, and they don't have any repositioning treatment of the null zone. If you examine these patients later, you see the persistence of the ascending null on eye movement recordings, and improving of visual function in that case of direction. That means that the eccentric null position actually doesn't change over the time. So, but what change actually? What change is the use of the eccentric null zone, and not the eccentric null zone, but the use that can change. So it appears that null zone goes away, and there are a lot of studies of Richard Elsa. Richard Elsa taught me this years ago, so it was interesting if he was here. It is very important that patients with eccentric null zone are almost always forced to choose between seeing well or feeling well. If they want to see well, they adopt an anomalous head position. If they just want to feel well, they do not adopt AHP. Of course, most choose to feel better over the time, so they posture, intermittently, or actually they do not posture at all. So, the etiology of this clinical phenomenon, so I mean a resolved anomalous head position, is not due to disappearance of the null position, but the lack of its use. This is very important to know this, because when to have to decide, if you want to do surgery early or not, maybe you can be worried because the anomalous head position can change or can improve. Actually, If it improves because the use of the anomalous position is improving, but not actually the mathematical null though. The second point is if the anomalous head posture, if it's present or not. So it should be better to say if it's relevant actually, because even if you have an anomalous head posture, you know, that should be relevant to do surgery. Most of the time, most of the surgery and also me, I consider relevant starting from 15 degrees, 10, 15 degrees. An important point to discuss is that anomalous head posture, when we evaluate patients after surgery, is always a soft outcome. I mean, because also sometimes a slight head posture improvement, you know, is sometimes taken as success, but success is not actually. And the head posture also depends on other factors, maybe on how hard the patient is trying to keep their head straight, and how hard they are trying to see. So this is important to evaluate when you have to decide if the anomalous head posture is relevant. And sometimes there is a kind of placebo effect for patients, parents, and surgeons. It's very important is what type of anomalous head posture, because surgery is totally different. We are facing with chin up, down, face turn, head tilt, a mix of above. Of course, there is a different muscle to operate. And also, if there is a convergence dampening, I learned by Barton Kushner from Lionel Cowell that if you add a -1 sphere on glasses where there are also a 6 or 7 prismatically ortho base out prism, you can dampen on nystagmus, and maybe you can improvement also over the time. Otherwise, surgeries could be fine. And the other important things is the presence or not of strabismus. When you have strabismus and nystagmus, you have first rule out, of course, fusion maldevelopment nystagmus, and make a difference diagnosis with the infantile nystagmus syndrome with a component related, with a latent component. Sorry. So I have prepared this flow chart for you. I mean, if you have a dampening of nystagmus with an eccentric position, so an anomalous head posture, and you have strabismus, and you check for strabismus. If you don't have strabismus, you can be sure there is an infantile nystagmus syndrome. But if you have strabismus, you have, of course, distinguish between FMN and infantile nystagmus syndrome. So first, you can close one eye first and the second eye first, and check if there is a change of direction. So if there is a direction, and so the first phase of nystagmus, if you close the right eye and you look at the left eye, and the first phase is an abduction, and the same for this eye, and the first phase in abduction, so always in abduction, it means there is a latent component. If this not happens, is in infantile nystagmus syndrome. If this happens, could be still both an infantile nystagmus syndrome with a latent component or an FMN, because we are talking about patients with strabismus. So to understand if we are talking about, if we are seeing an infantile nystagmus syndrome with latent component or FNM, when you close the eye and you see that the eye, as a direction is a fast phase in abduction, the same here, fast phase in abduction, just keep just keep the eyes closed, one eye closed, and put the closed eye in abduction and see what happens on the eye in adduction. If there is a change of direction, so the eye, the fast phase in abduction, so the eyes goes in adduction. If you change the fast phase, now it's in adduction, that means that the infantile nystagmus with the latent component. If it does not happen, it's an FMN. And I show you a video. This is a patient with nystagmus and strabismus. And you can see if you close the eye, you see the right eye, the first phase is in abduction. And when it moves in adduction, the first phase is still in abduction. So it doesn't change direction. If it doesn't change direction, it means is a fusion of maldevelopment nystagmus, and is using the Alexander law to dampen the nystagmus in adduction. And the other things, that the last thing to see before planning surgery if this patient has an aperiodic, asymmetric, alternating nystagmus. We have to observe the child for several minutes to see if there is a change of anomalous head posture, or also you can close one eye, you can patch one eye and see if there is a change of direction of the nystagmus for several minutes. Generally speaking, it's 5-7 minutes. This is very important when you have to plan surgery of nystagmus. Thank you very much.
Yeah, Serafino, that was a very good talk, very nicely elaborated, and very nice parameters you have put out, and the like differentiating points between INS with latent and FMNS with latent component. So we go to the next speaker.
So a patient with nystagmus is forced to take some head postures that may be bothersome. So managing these head postures is all that is needed in some patients. I invite Dr. Maria, who will discuss about managing alternating face turn.
Thank you. I'll just pull my talk up. Okay, so thank you for inviting me to be part of this webinar. I've kept my talk reasonably straightforward. I'm going to discuss how we manage alternating nystagmus. So I'm just going to whiz through this because I tend to put this slide in every talk. For every patient with nystagmus, when you see them, you need to differentiate those that need neuroimaging. In PAN, it's essentially those that or aperiodic alternating nystagmus, essentially those that are acquired, need neuroimaging. To do that, you take a thorough history and examination, you investigate appropriately before you decide how to manage them. In this, we did discuss these last time, so in this talk, I'm just going to focus on management of alternating nystagmus. So clinically, alternating nystagmus is, as the name describes, is a repetitive cycle of right and left beating nystagmus. It could be periodic, could be aperiodic. They may or may not demonstrate an alternating head posture. Where they do, it's to minimize nystagmus based on Alexander's law. Alexander's law is where the nystagmus is more pronounced when the gaze is directed towards the side of the fast beating component. When you see patients, you need to make a note for a changing head posture. So if there's a difference between what they describe at home to what you see in clinic, to photos, to videos, you need to bear in mind this may be an alternating head posture rather than a consistent head posture. You should ideally observe them for at least 4 minutes in acquired and 8 minutes in congenital. The cycle tends to be longer in congenital. I suppose strictly speaking, you could see them for half this time, but the cycle tends to be 4 to 8 minutes. And always listen to patients and parents. EMRs, IMINT recordings can be very helpful, and I'll show you why in a second. Now I've just got a video here of PAN. I haven't consented my own patients for using videos for webinars, so I've had to take this from the internet. So this is a patient with a right beating nystagmus. It is the shortest video that I could find. So if you just bear with me. And then soon this will slow down and change direction. So here we go, the nystagmus slows down. And now he switched to a left beating nystagmus. Fast phase is left. So just showing where if you're fortunate enough to have access to IMINT recordings, it really does make life so much easier. This is a child with an alternating head posture, normalized family history of albinism and chiasmal misrouting on EDTs. when you think of albinism, you need to be thinking about PAN a little more than with other types of infantile nystagmus. And for those of you that aren't familiar with Eyman recordings, here's a velocity trace of the horizontal Eyman recordings, and any movement down is left beating nystagmus, and movement up is a right beating nystagmus. And you can see, even though it's noisy, he switches from a left beating nystagmus to a right beating nystagmus. And this is how he continued throughout the recording. Adults, obviously even easier to see. This is an adult with a definite history of acquired nystagmus due to cerebellar atrophy. Again, this is a velocity trace, and this adult had, you could see, left beating alternating with right beating, had a cycle of 220 seconds in total. And just to show you what happens at the changeover. So this is the same patient switching from left beating nystagmus as a position profile and velocity profile. The nystagmus then slows down and switches to right beating nystagmus with increasing frequency and amplitude. So when you manage these patients, there are a few things that you need to consider. First of all, it's really important to manage the expectations. You need to think about what you're trying to achieve and what the patients expect you to achieve. You have to be realistic, preferably before treatment. Otherwise, even if your treatment is perfect, if the patients were expecting more, they're going to be disappointed. So you do need to explain clearly that you're not aiming to abolish the nystagmus, but to dampen it. It tends to be the acquired PANs that are happy with treatments, because you're trying to dampen the, improve the oscillopsia. The congenital PANs tend to be a little more disappointed. With any types of treatment, not just for nystagmus, but in general, you need to balance the risk-benefit ratio. For PAN, we're looking at pharmacological versus surgical. And then finally, for not just PAN, but for all patients with nystagmus, you need to think about counselling and support for both the patient and or the parents. It is well known, and we've published, and other people have published, on the effects of nystagmus. The anxiety, depression is much more common in adults with nystagmus. We haven't looked at children, but we're assuming that the same will, but that's also the case. So you do need to bear this in mind. It does have a quite significant impact on the patient and the parents. So first of all, I'm going to discuss medical treatments. So the medical options, if you're looking at medications, the perfect drug will reduce or eliminate the oscillation with few or no systemic side effects. There'd be no long-term effects because lifelong therapy is required. No teratogenic effects, so you can use it in women during childbearing age, and it would be cheap because you'd be thinking about a lifetime cost. Now, there's a long list of medications that have been used in nystagmus. The ones that I use most commonly are gabapentin, mantine, and baclofen, but baclofen is the one that has the most evidence for treatment in periodic alternating nystagmus. Now, baclofen stimulates the inhibitory GABA B receptors on the glutamate receptors. It's commonly used for chronic spasticity, so our pediatricians and our adult physicians are pretty comfortable with prescribing it and monitoring where needed. It's readily available and it's quite cheap. The prices I put here are for the BNF drug tariff. Obviously, this will vary, so it's just to demonstrate it's not a particularly expensive drug. Common side effects that limit the use tend to be drowsiness. That it's and what many of us use as first-line treatments. It's more readily available now since nystagmus in MS was been listed as a national formulary. It's also quite cheap. Right, sorry about that. So am I? I'm back again, I hope. There is less evidence for use in PAN, but it has been reported in nystagmus associated with MS more than anything else. I've yet to see a patient who has had success with mantine over baclofen, but it has been reported. Gabapentin is a drug that is very commonly used in nystagmus, and most of us that treat nystagmus medically are quite comfortable with. It was designed to mimic GABA, but doesn't bind to the GABA receptors. It probably works via the voltage-sensitive calcium channels. It's very readily available and is also quite cheap. In the UK, it's now controlled drug, so it's a little bit more difficult to get GPs to prescribe longer term. The common adverse effects are fatigue, stomach upset, and lightheadedness. And where it's used for nystagmus, PAN or not PAN, just need to be aware that especially in young men, that personality change and suicidal thoughts can happen as an adverse effect. So generally there's evidence for use in nystagmus, but it tends to work better when we've looked to analyze our data for the pendular subtype of nystagmus rather responded. So next I'll go on to the options for PAN. So what we do in practice, maximal horizontal recessions, prevention toxin here as well. We do use a lot of toxin at Moorfields, but really if you're looking at PAN, it would be for diagnostic purposes. Only treatment. So for example, if you want certain whether it's PAN, if they have a preferred head posture, say periodic, then you may want to use toxin to simulate effects of surgery. I've mentioned tenotomies in the Sinski procedure. These aren't things that I do, but I just thought I'd
We also lost Maria.
sorry, I don't know why.
Your
My sons are.
Internet is unstable. Audio is not very clear, Dr. Maria.
It was that my sons were using it. They're both off unstable. I'm sorry about that. With this previously, let's hope. So there's evidence for use, and I've certainly had good effects with maximal horizontal recessions. You can often get long-term recurrence. Mostly this is very long-term, 10, 15, 20 years post-operatively. But again, with surgery, especially with surgery, you need to manage expectations before and not after. Make sure they know what to expect following surgery. They will still have nystagmus. It may recur longer term, and they need to know this before rather than when they come back and think something has gone wrong. The other procedure that I will sometimes do for PAN is reversal or supplementing previous surgery. So this is essentially people that have previously had head posture surgery for a preferred head turn, and the head posture switches to the other side either immediately or over time, because people haven't realized that it's pan or alternate or an aperiodic alternating head posture. And for these, I'll often either recess the previously resected muscles or recess the unoperated muscles, depending on the original procedure. Obviously, the idea would be to try to avoid in the first place, but it's always easier said than done. And if there is a preferred head posture and you aren't sure if it's an alternating nystagmus, you could consider toxin preoperatively to simulate the effects of surgery. Tenotomies I will mention, but I don't do tenotomies. Tenotomies people describe as cut and paste. Essentially, you tenotomize and reattach the muscles at the original insertion. You will obviously have scarring of the conjunctiva and the muscles and all the risks of strabismus surgery because you're going through the process of strabismus surgery. NICE in the UK suggests that there isn't enough evidence for treatment based on four case series, and we don't do this routinely. And the final thing, which I will just mention, but it's not something that I do, is a Sinska procedure, just in case anybody was wondering. This is subtotal anterior extirpation of horizontal muscles. This was first done in 2002 by Dr. Sinsky and has been more recently performed by Dr. Lingua. And here is the first publication. It's not a routine procedure and not recommended at present, but they are currently, when I last spoke to Dr. Lingua at a conference, they are currently trying to modify the procedure, but it's not something that we do or that I do routinely. So I'm going to finish off with a very brief case. This is a 22-year-old with acquired periodic alternating nystagmus who's basically had all the treatments that I've, lots of treatments for her pan. So she, without treatment, she had visual acuity, corrected visual acuity of 6/12 with both eyes open, with very problematic oscillopsia and a large alternating head posture. She'd tried gabapentin, but was quite drowsy on this. She had no effect from memantine and did really well with a very, very high dose of baclofen. In that, vision was 6/4, right eye 6/5 with dampened oscillopsia. But she wanted to discontinue the medication. She didn't want to be on medication constantly, particularly when she was thinking about starting a family. So I offered her full muscle recession, but did explain that it may recur long-term and she may also need baclofen again at some stage. We discussed toxin because she wanted to simulate the effects of surgery. So she was a very, very well-informed lady, and over about 6 to 9 months, she decided she wanted to trial toxin first. It's not something that I would recommend as a treatment, or you have to pick your patients very, very carefully. But she had 4 muscle horizontal toxin, and this is her nystagmus in left gaze pre and post 4 muscle toxin. She tolerated toxin very well without any adverse effect. So she had botulinum toxin to the medial recti and the lateral recti. And as you can see, even if you aren't used to looking at these recordings, there's a reduction in amplitude, frequency, obviously intensity, and increased foveation time. So she was really pleased with the effects of toxin, although we had discussed that it was for diagnostic purposes only and not something that I would do long term. And she has gone on to have 4 muscle horizontal recession with similar iron recordings to these, so I didn't put both up. And 3 years down the line, she's still doing very well with best corrected visual acuity of 6/5, dampened oscillopsia, and
Maria, your voice is breaking off. Dr. Maria, the voice is breaking off.
Haven't changed. Oh, you need to, is that better? I was hoping to get through my last slide. I'm
Yes,
sure
yes.
it is.
Dr. Maria, yes. Yes, we can see you now.
So yes, I just about got to the end of my talk.
Maria, there's a very good talk, very difficult topic actually. Periodic alternating nystagmus was difficult to manage. What is your experience with patients after retroequatorial recessions? Any of your patients have developed exotropia?
So far had any patients who have developed exotropia. I have, I must admit, I'm a little bit more conservative, and I tend to worry a little more. So I do sometimes leave one of the muscles on adjust, not to assess the nystagmus, but to make sure they don't have a manifest squint afterwards. So in the adults that I've done, I've left the muscles on adjustables just to reduce the, I haven't yet had to adjust anyone because of a manifest strabismus, but more to reduce the likelihood of inducing an exotropia afterwards. So I haven't so far, and hopefully the leaving muscles on adjustables will minimize that that complication.
Okay, and if you have a periodic alternating nystagmus patients who have distance and near different head postures, like right head posture for near, and distance patient has got a left head posture. So you still proceeded with the retroequatorial recessions in both the eye?
I still would, because it's, well, you can't really function with one, you can't really manage one head posture. So I still would do the maximal recessions in both,
so
if they wanted something.
So Maria, you are doing 10 and 7. That's what I remember, 10 lateral rectus and 7 medial rectus.
10 and 7. I know some people do more than that. Yeah, I know, as with many of us, I will often discuss things with him, but I found that 10 and 7 seems to work fairly well, in my hands anyway.
Can we go to the next talk?
So I request Dr. Lionel Cowell to talk us about managing vertical head postures. Dr. Cowell, over to you. Dr. Cowell, can you please share your screen?
I've unmuted and I'm sharing my screen, and here is, and can you see my slides?
Yes, we can see your slides.
And I'm using, and good. Well, firstly, thank you very much for having me. And in infantile nystagmus,
Dr. Cowell, I think in the presenters mode, sorry to interrupt, can you?
It's in the presenters mode.
Can you go back and then share your screen?
Can you go back and share the screen?
Is that better?
Yeah, that's better. Yes, yes.
Good. So any one patient with infantile nystagmus can have several nulls, and Dr. Annette Spielmann, Alain's mum, introduced me to the 3 T's, the turn, the tip, and the tilt. And of course, today I'm going to be talking about tips. And these are version nulls, eccentric nulls that drive abnormal head posture. The patient will tend to use the null, and Max discussed this very nicely. The patient will tend to use the null that gives better vision and that is orthopedically more comfortable. As Richard Hurtle says, many patients do not posture most of the time because they cannot do so comfortably, and if they could, they would. And often the null that the patient chooses is a compromise between best vision and comfort. And I'm having a little bit of trouble changing slides. Now you can see a tip across the room. You have to get close to examine a child to find a convergence null. And if you find a convergence null for near, that I've abbreviated CNN, you now have to look for a convergence null for distance, CND. And how do you do this? You add some prisms, and you usually have to add a little minus for the CAC ratio to look for the convergence null for distance in the office. If it is present in the office, I give the child these glasses to wear in real life for a week or two to see if the patient prefers this vergence null to the previously used version null. And this is very important because if the patient prefers the vergence null, I will do a BMR, so-called artificial divergence surgery, introduced and popularized by Annette Spielmann, and this is often the best option. How common is a convergence null for distance? Roughly 1 out of 3 patients who walk in my door with nystagmus will have a convergence null for distance, so it's fairly common. Why bother looking for a convergence null for distance in someone with a tip? It's because vergence surgery, artificial divergence surgery in nystagmus, is often more effective than version surgery, so-called Kestenbaum-Anderson surgery to shift the null. Vergence surgery is often more effective in obtaining and maintaining a large primary position null. For example, let's look at Joshua, who's a moderate hyperope, vision's down a little bit, and he's got some evidence of albinism. And with his contact lenses, he's got quite a large tip and a face turn. And with prisms over his contact lenses, this straightens both the turn and the tip. So the next step is firstly to give him a trial of glasses over his full plus. And if effective, the choice is to continue glasses or consider vergence surgery. If it's ineffective, then we consider version surgery, as indicated there, for the tip and the turn. If the spectacle trial in real life shows that his convergence null for distance is frequently used, the best treatment is a bimedial recession, artificial divergence surgery, plus or minus cut and paste, thank you Maria, of the lateral rectus. If the spectacle trial shows that he still has some tip up, but better than before, then a combination of the vergence, and version surgery. Now, the tip up. A tip up, the depressors are recruited, especially the inferior rectus and the superior oblique. And this causes a reduction in the nystagmus, and so we have a null zone on down gaze. How does this happen? The likeliest explanation is that the excess innervation by the inferior rectus acts as a brake on the nystagmus, and that improves the vision. But there may be some other innovational magic that also is in play. So here's typical patient, 6 on 30, obvious infantile nystagmus, tip up, the vision improves to 6 on 12, and I just need to move, and the excess innervation acts as a brake, B-R-A-K-E, I've just gone too many, acts as a brake on the infantile nystagmus. I'm having some good. We would normally recess an inferior rectus for an eye that has hypertropia. If we recess an inferior rectus for an eye that does not have hypertropia, this is going to produce fixation duress in the primary position. What is this thing called fixation duress? The fixation duress results in excess innervation to the inferior rectus, to the recessed inferior rectus, to maintain primary position. And that's similar to the excess innervation that acts as a brake on the infantile nystagmus. And this may be how the inferior rectus recession recreates the effect of the down gaze null, but now in primary position. So after inferior rectus recession, we have fixation duress in primary position, causing excess innervation in the inferior rectus, and this acts as a brake on the infantile nystagmus, and the down gaze null is now shifted to primary position. And we will see later how the inferior rectus recession alone is inadequate about half the time in producing the desired effect. Tip up. So we achieve the tip up effect on inferior rectus innervation by recessing the inferior rectus, and no tip up is now needed to break the nystagmus because of the fixation duress. Can we augment this effect if we need to? Yes, we can augment it by doing a larger inferior rectus recess, or by doing superior rectus resect or plicate, or by doing superior oblique weakening, and all of these cause even more fixation duress. Let's have a look at the literature. Rich Hurtle, 10 years ago. He collected 13 patients with a tip. 13 of them had a tip down and 11 had a tip up. And his formula for operating on these patients: tip down, superior rectus recess, inferior oblique myectomy, and one horizontal muscle per eye as well. Tip up, inferior rectus recess, superior oblique tonectomy, and one horizontal muscle per eye. I think it's important, if you're going to look at a surgical recipe from someone like Rich Hurtle, who does a large number of these surgeries, to ask him in great detail exactly how he does every small step. Because if you want to get the same great outcomes, you need to follow his recipe very closely. After the surgeries, all the patients had a mild vertical gaze paresis in the intended direction. Average acuity improved. Most patients had improved acuity. 20% of the patients had a significant improvement in acuity. If you're doing a large inferior rectus recession, you're likely to have a net in-cyclo effect. If you're doing superior oblique tenectomy, you're likely to have a net ex-cyclo effect. So the net expected torsion is 0. And Rich Hurtle has not had any, and I have not seen any patients who've had persistent torsional problems. And the same, I've talked here about a tip up head posture, but the same applies to a tip down. Another look at the literature from Monty Del Monte's department at Kellogg in Michigan. 20 patients, 4 of them were acquired nystagmus. 11 of them had recession alone as the first procedure. So half of them had recession alone. Of that half of those, the operation didn't really work and they needed a resect procedure. And half of the patients had vertical resect surgery as the first procedure. Of those that had recess alone, they all had surgery no more than 10 millimeters. 6 of them, half of them, the tip was no better, in fact was sometimes worse. That's in the box here in their results graph. Half of them, the tip was no better and sometimes worse, and they had a second surgery. Whereas those who had combined resect surgery all had good results. And they recommended for 10 to 15 degrees of tip up or tip down, the patient have a total of 12 millimeter surgery on each side, 6 millimeter recess, 6 millimeter resect, and so on. Acquired torsion. With the large inferior rectus recession, you're likely to have a net in-cyclo effect. With the large superior rectus resect, you're likely to have a net in-cyclo effect, and vice versa for the tip-down head posture, but actually none of their patients had symptomatic torsional problems. Another look at the literature from Marty in New York. Concerned that many people would feel uncomfortable about doing bilateral superior oblique tenotomies or tenectomies in someone who confused. He did posterior 7/8 tenectomy, and he used these doses of inferior rectus recession. And he had very good outcomes on all of his 13 patients, roughly perfect in half and near perfect in the other half. Acquired torsion, inferior rectus recess is of course a net intorta, and superior oblique intorsion effect, because the anterior 1/8 is still intact, you're going to also have a persisting intorsion effect. And he had no torsional problems in his series, though Dr. Shetty did report one patient of his who, after a similar operation, had torsion for some months that I think eventually got better. Subsequent surgeries, with the Hurtle and Steele approach, there's room for horizontal surgery without real worry about anterior segment ischemia. With the vertical recess resect, there is a worry about anterior segment ischemia if the patient needs further surgery. My recommendations to you: look hard for a convergence null for distance. If it's present and it's proved useful in real life, the best treatment for the vertical abnormal head posture is a BMR. Follow Rich Hurtle's surgical recipes carefully and get the book that Rich Hurtle and Lou Deloso wrote. You can now download it for free from Lou Deloso's website. I'm very grateful to everyone who's taught me about nystagmus. Dr. Reineck, when I was his fellow at Wills a little too long ago, he was doing eye movement recordings, and Maria, he was the first one to publish that large horizontal muscle recessions were only useful in PAN. They weren't useful in other types of nystagmus. John Taylor was my predecessor at the Anterior Hospital in Melbourne. He had an interest in the surgery for infantile nystagmus, and he was one of the first people to show improved acuity in a significant minority of these patients. Alain's mum, I visited her in France. It was no problem. I'm happy to go back. And she had immense experience, and she had her own laboratory in her office, and she did very clever things with nystagmus and was a very generous teacher to everyone in France and in America. And unfortunately, Richard Hurtle, who's not with us today, he comes from everywhere, a few places in America and China, and he was a great teacher. And thank you to them, and thank you, Dr. Shetty, for having me with you today.
Very nice, doctor. Very nice talk. Very extensive, very exhaustive, very good. It was very interesting, and a lot of points you had put forward. It's very interesting that read the people who are attending. You'll get a lot of good points how to manage this type of difficult type of patients who have this tip up and tip down.
So after managing these vertical head postures, now let's hear from Dr. Birsin about her management protocols when nystagmus coexists with strabismus, which is taken care first, why and how. Dr. Birsin, can you share your screen? And unmute yourself, please.
You have to unmute.
Dr. Birsin, you have to unmute yourself.
Okay.
Yes. Yeah.
And I try to share my. Yes, I now I'm unmute, and I try to share screen, and may I begin?
Your screen has
Yeah,
not visible to us.
Not visible.
Yeah,
Yeah,
there it
now
is.
it's visible.
Neye gitmedi? Açtım.
You can start, Dr. Birsin.
Okay now.
Şimdi tamam mı?
Tamam oldu ama şey kapandı.
Neyi kapandı? Şu an görünüyor mu? Is it okay?
Yes,
Yes,
yes.
yes.
Niye gitti?
Did you see now?
Yes, we
Yes, we can see your slides.
Okay, with the whole screen or some screen?
put it to the full
Is it
mode.
okay now?
Can you pull it to full screen mode?
It's now is full screen.
Yes, there it
yes.
is, yeah.
Yeah. Good.
Okay, I will turn back again. I'm so sorry. I don't want to take time. It's full screen, but
Sorry to interrupt, Dr.
I don't.
Blessing. Your share screening is still not visible to us.
Okay. May I talk now?
No, your
Yes,
screen
yes.
is
Screen
not
is not
shared.
shared. Your screen is not shared.
Tatlım şu an Zoom'a giremiyorum. Zoom'a girdim. Share screen yapınca çıkmıyor. Bunu koyduğumda Zoom kayboluyor.
Share screen yaptın mı?
Share screen yaptım tatlım. Share screen 40 kere yaptım hem de.
Nasıl işte daha evvel olur.
Hı hı. What about now? Is it okay?
Gelmedi.
No,
It has still not appeared on.
it is not seen. No.
I think it's the lag, Dr. Blessing.
Is it okay now?
Yes,
Now
yes.
it is seen. Yes, yes.
Are you seeing my slides?
Yeah, now we can see your slides.
Is okay. Okay, thank you. And with full screen, okay?
Yes, it's okay.
It's full screen şu anda.
Okay. Okay, thank you for organization committee for their kind invitation, first of all. And following our very kindful presentation, I will talk about managing nystagmus when it's coexisting with strabismus, how to measure and manage. I like to begin reminding the surgical treatment indications. They are to eliminate abnormal head posture to decrease the intensity of nystagmus for patients without abnormal head posture, to improve visual acuity, contrast sensitivity, and foliation time. And today my subject is to correct strabismus and to restore binocular function. Strabismus and nystagmus been together in several forms. Strabismus alone, strabismus with null point and abnormal head posture, like horizontal, vertical, torsional. Strabismus with periodic alternate nystagmus, strabismus with organic problems. General principles of surgery in nystagmus. First of all, for placing the null point in primary position, direction as the abnormal head posture. Face turn to be corrected only with fixing eye. Surgical plan should be based on greatest amount of head posture at distance, and strabismus can be corrected by operating on fixing eye or non-fixing eye. Preoperative evaluations are similar as the normal nystagmus patients, but if there is strabismus, it also needs meticulous and detailed motility examination, include visual acuity measurement, correction of refractive error, and achieve best corrected visual acuity. Ocular, motor, and standard clinical evaluations include motility evaluation, eye movement recording, head posture measurement, and laboratory and special tests. If the patients had not abnormal head posture, standard motility examination, including ductions and versions control, prism cover and alternate prism cover several position for distance, near and near with accommodative object, and for all cardinal gazes position, and standard
Your voice is breaking, Dr. Birsen. Your voice is breaking.
performed. Strabismus evaluation in patients with head posture is a little even with
Dr. Birsen, your voice is breaking off. No, you have to unmute yourself, Dr. Birsen.
Yes.
Yeah. Yeah. Can
Okay.
you share your screen? Share screen.
Okay, again, okay. Okay.
Maybe Lionel may shut off the video, because it will be better if the video of all the participants is shut off.
Is it okay now?
Yeah. Can you share your screen? Your screen is still not shared. Share your screen.
I pushed the screen share, but I think I pushed several times. Isn't
But
it?
the screen is not being shared.
Again, I tried. Now?
No, it's not coming.
Okay, last time I tried. I'm so sorry, but it's not my fault. Okay. Şurada bir şehir var, oraya inemedim. Is it okay now?
Yes. Now it is coming. Yes.
Okay. Okay. I think I'm still the.
You have to go, I think, behind the slides, because we could not hear your voice.
Did you see now?
Now we can see. Can you go maybe 1 or 2 slides behind?
Okay, I tried to go previous slides, but I couldn't.
You're not able to go. Okay.
Okay, I will turn later if I couldn't. I couldn't control the slides.
Okay.
Stay stable. Oh, I couldn't go forward or back.
Right.
Back and forward.
I
Actually,
couldn't
that
go.
option is just below Dr.
May I
Gupta.
turn back, stop share, and try to manage my slides again?
Yeah, sure.
Yeah, yeah.
Okay. Did you see?
No, your slides are not seen still.
No, Dr. Bisson. Can you try now?
Dr. Bisson, can you try now?
I think you've lost Dr. Birsin, so we'll get back to her. So we'll listen to her after this talk. So our last.
Oh, Bisson, she joined.
Okay, she's back. Yeah. Okay.
You can ask her to come later.
Unmute yaptın mı kendini? Ha,
Did you see now?
Yes, we can see your slides now.
Is it okay now?
Yes, we can see the slides and we can hear you.
Did you see now? Slaytlar hareket etmiyor bu defada tatlım. I can't manage. Did you hear me? Devam mute
onların
oluyor.
sesini duyamıyorsun sen. Bir konuşmada bir problem var.
Devam mute oluyorum.
Seni duyuyoruz diyor.
May I continue my presentation? I don't hear your voice.
Yes, you can.
Yes,
Yes,
yes.
yes.
You can
Okay.
continue.
Yes,
Did you see my? Okay. Did you see my?
We can see your presentation.
I think we have lost Dr. Birson again. So I invite Dr. Spielman to talk on managing recurrent head postures after nystagmus correction. We'll get back to the previous one once she's connected to us. Dr. Spielman, can you please share your screen?
All right, I can start.
Yeah, you can start. Yes.
Can you see my slides now?
Yeah, we can see your slides.
Okay, so I'm going to talk about the recurrence of head postures after nystagmus surgery and the available surgical options.
Dr.
And
Spielman,
I try to
can you please enlarge the screen?
Can you enlarge the screen, Dr. Spielman?
larger screen, sure.
Yeah.
Okay, and I hope that will be a practical guide.
Okay.
This is an example of a horizontal head turn, and this boy can benefit from a two muscle procedure, recession of two muscle. This is Anderson procedure. And it can also have four muscles procedures, such as the Kestenbaum procedures, with recession of two muscles and resection of two other muscles. When this kind of head turn is operated on, surgery will usually make the head turn disappear. But you can have recurrence. If the recurrence happens a few weeks or a few days or a few weeks after surgery, this is probably a failure of surgery because of insufficient surgical amounts of surgery. But if recurrence occurs months of years after surgery, this is not a problem of amount of surgery, not a problem of millimeters. And you will have three different situations. The first one is recurrence of the same direction head turn. The other situation is recurrence of an opposite head turn. And the third situation is the recurrence of a vertical head turn. Let's talk about now a boy with vertical head turn who can benefit from two muscle or four muscle procedure on the vertical rectus muscles. And he also can have recurrence of his head turn, same direction head turn. The occurrence of opposite vertical head turn is really unusual, but it should be possible. And this boy with vertical head turn can also have a horizontal head turn afterwards. So we will talk only about the situation with a boy with a horizontal head turn operated on, and then recurrence of head turn. The first situation, the head turn is on the same direction. The reason might be insufficient of surgery, but not years after the first surgery. Maybe there are some brainstem changes over time, and maybe this is because of muscular remodeling, because there can be a contracture and slack muscle can become the fibrilla can change. So this boy, if he had already been operated on two muscles, you can do two more muscles and transform the intestine to a Kestenbaum procedure. But if this boy had already been operated on 4 muscles, usually it's difficult to recess more muscles that has been previously recessed 7, 8, 9 millimeters. You can try, but usually you will not get many more millimeters available. And usually you will have to resect further the resected muscles. You have to expect limitation of ductions, and you can have an opposite head turn for a few days or a few weeks due to the tightness of over-resected muscles, but it usually won't last long. And in some cases, you can consider artificial divergence surgery as an option, but all the conditions has to be fulfilled. So all the question is, how much can a muscle be recessed or re-recessed? I think that medial rectus can be recessed 12 millimeters from the insertion, lateral rectus a little bit more. But about resection, it's difficult to give numbers. I think it depends on elasticity of the muscle that you will find during reoperation. It will be helpful to use traction tests, to look at the position of the pulleys, and the surgeon's feeling is important to resect previously resected muscles. You have to know that unusual amounts of surgery may lead to strabismus and diplopia, and that medial rectus and lateral rectus can react differently to large amount of surgery. So consider adjustable suture as if the age of the patient is consistent with this. So as I said, you have to expect limitation of duction for a few days or a few weeks due to tightness of over-resected muscles. And think about leash effect and tight rectus syndrome. I will show an example. The tight rectus syndrome is a vertical deviation when the thigh muscle cannot be stretched because it has been over-resected. So here is an example of a boy with a nystagmus. The nystagmus is higher in right gaze and less in left gaze. That's why he used this head turn to look at distance. So he was operated on recess of 2 horizontal muscles and resection of the other muscle. But 3 years later, he comes back with a recurrence of the head turn, same direction, and he's still avoiding looking to the right. So he was operated on again, and I resected the 2 muscles, the lateral and the right lateral and left medial 7 more millimeters. He is now straight, no head posture, and always look at the absence of strabismus because the over-resected muscle can change parallelism. This is not an example of nystagmus, but just to show tight lateral rectus. Look here at the vertical deviation during attempts to left gaze because the lateral rectus is too tight. It was, in fact, for strabismus, but never mind. Another situation is the recurrence of the head turn, but to the opposite direction. It's unusual is the cause of this head turn, opposite head turn. Maybe it's also changes of the brain stem over time. But what, in fact, the usual reason is that the boy had pre-existing alternating head turn. So you have some options. If 2 muscles were already operated on, you can recess the 2 other ones. It will lead to a recession of the 4 horizontal rectus muscles. But if the 4 rectus were already operated on, you will have to recess the previously resected muscle, and it will lead at the end to a recession of the 4 horizontal muscles. Of course, you can consider artificial divergence surgery as an option. And also it's popular in Europe. You can consider Faden operation in cases of early onset strabismus responsible for the two head turns. To avoid such situations, you will have to look at risk situation before any operation. This is a case of periodical, rather aperiodic alternating nystagmus, more nystagmus in head turn. Look here, head turn to the left, and a few minutes later, head turn to the right. That's not unusual in albinism. And vertical null is also not unusual in albinism. The other case is a case of left head turn at distance fixation. She's reading later, but at near fixation, you will have the opposite head turn. Often these this kind of two opposite head turn and can be improved by artificial divergence surgery. Look at blocking convergence. And the last situation you have to look for is head turn depending on the fixating eye in cases of early onset strabismus. They have two opposite. These children have two opposite head turns depending on the eye, which is fixing. Okay, here is the main head turn, which is not only horizontal, but it's also slightly vertical. In fact, the right eye is fixing there, but sometimes if you ask to turn the face, she will use the other eyes as a fixating eye. And these are a risk situation for recurrence with an opposite head turn. And the last situation is a case when the horizontal head turn turns to a vertical one. This is not unusual in albinism. This boy was operated on the 4 horizontal muscles for a huge nystagmus with high amplitude nystagmus. This is post-operatively, but if you look carefully, this boy has also a chin-up head turn, not too much. So I didn't operate him again for the vertical, but sometimes the vertical turns out to be disabling, and sometimes you will have to operate also the vertical. So why? Because there is probably pre-existing vertical head turn, and that's not unusual in albinism. And you have to rule out vertical head turn due to strabismus, patterns, strabismus with DVD, and sometimes trochlear palsy. So surgical options are, if 2 horizontal muscles were operated on, you can choose between the vertical 2-muscle Anderson procedure or vertical Kestenbaum procedure. But if the 4 horizontal muscles were already operated on, you will have to avoid surgery on the 4 other vertical rectus muscles because of the risk of anterior segment ischemia. So be careful and only resist 2 vertical muscles, and you can discuss additional surgery on the oblique muscles because they don't lead to anterior segment ischemia. Because the anterior ciliary vessel comes from the rectus muscles. And there are some tips to avoid total ischemia and inflammation of the anterior segment. You have to know that there are less risk in young patients. You will have to wait for a sufficient delay between 2 operations because it gives time to develop collateral vascular branches. If you have to operate, try to avoid limbal incisions. And I tend to use plication dissection because you can see here on this picture that the ciliary vessels are not cut in case of plication rather than resection. And of course, if you're a good surgeon, you can discuss careful dissection, preserving these vessels, but it's difficult. And I personally, I'm not at ease with such procedures. So to sum up and to give some message, recurrence of head posture is used in surgery. If the head turn come back in the same direction, you can enhance your surgical numbers. If the head turn goes towards the opposite direction, it will lead to recession of the 4 horizontal muscles. And if the horizontal gets vertical, another surgical step is still possible, but caution is required. And as a surgeon, you must be at ease with how much a muscle can be recessed or resected. And I think that adjustable sutures can be useful not to induce strabismus. The surgeon must be familiar with the risk of anterior segment ischemia and how to prevent it. And I think additional knowledge about surgery of the vertical rectus is useful because you will recess and resect with large numbers, and it will induce cyclotorsion, lead changes, and it can also lead to overcorrection after inferior rectus recession. So global knowledge about ocular motor muscle surgeries is useful. Thank you very much.
Alan, that's a very good talk, very extensive. And because this is the most difficult to cover, actually, the recurrence of head posture after the nystagmus surgery. And it's also always an enigma to treat this type of patients.
Thank you.
What is your take on patients who undergoes modified Anderson's procedure and then presents with the recurrent head posture to the same side? How
You
you
mean
tackle those type
augmented procedure with large numbers?
No, if the patient has a right face turn and
Yes,
has undergone left 12 mm lateral rectus recession and a right 10 mm medial rectus recession, and he comes back again with the right side head posture of 15 degree, how you manage those type of patients?
I'm not sure I have understood your question. A man with a patient with a right face turn?
Right. Yeah, he has undergone left lateral rectus recession of 12 mm.
Yes.
And a right medial rectus recession of 10 mm.
Yes, so 2 muscles.
2 muscles done, and now he comes back again with the recurrent head posture to the right side.
Same side.
Same side.
Yeah. Okay. I will resect the 2 other muscles.
But how much you advocate?
Usually, I do at least 8-9 millimeters. I often tend to do more than it's usually recommended, but in my hands, I think it's safe.
Okay. And in patients who develop a vertical head posture after 4 muscles surgery for an
yes, he has a vertical 4 muscles, right?
Yeah, and if your patient has a horizontal head posture and he undergoes 4 muscle surgery and now he comes back with a vertical tip down or tip up, do you prescribe them prisms? As Dr. Cowell has said that we should give them horizontal prisms to induce to see for a Vergence null, or you give them vertical prisms, or you give them vertical prisms for the tip up or tip down of who presents after 4 muscles.
Yes, I will look for convergence blockage at near.
Okay.
Clinically or with prisms, but it's rather rare that it's enough for vertical head turn. Okay. Usually I will recess 2 muscles for a chin up. I will recess the inferior rectus muscles, and for chin down, I will recess the superior rectus muscles. Well, in fact, I always do large numbers.
Okay. Thank you, Dr.
On the inferior rectus, I'm always scared of induce in certain temporal to the temporal side. It's not a simple recession. You can recess and shift lateral torsion.
Okay.
It's a feeling. I have not made a study about it. This is not evidence-based medicine, but I think you have to do something not to induce cyclotorsion when you do large recession of inferior or superior rectus.
Okay.
It's just a tip. You're not obliged to do so, but I think it can be useful.
Useful.
Yeah,
Okay, thank you, Dr.
the problem is, can I?
Yes, Dr. Serafino,
Sure.
yes.
Yes, Alain, I agree with you. I mean, the problem is if you do a large recession in inferior rectus and you want to transpose medially or temporally, it depends all on what you want to correct. If you want to correct the A pattern, you have to put medially. If you want to correct the torsion, you have to put them laterally. But you know, even you worse something. So if you want to correct the A pattern, you worse the torsion will worse. If you want to correct the torsion, the pattern will worse. That's the problem with this kind of recession.
Yeah.
So if they are fusion patients, that's the problem.
Yeah, I will add that if you do large recession and large resection, you will limit the amplitude of versions, but it doesn't matter. In fact, the patient never complains about it.
Yeah, sometimes I do the inferior rectus recession and I work on the superior obliques, actually.
Anyway, I used to have large head turn. They never complain if you do too much, in fact.
Okay.
Dr. Birsen, can
I
you
try again.
Yeah,
I will
yes.
try again.
Yes.
Okay. I hope you see now.
Yeah, yes, we can see now, yes.
Okay. Strabismus evaluation in patients with head posture is a little different. First of all, abnormal head posture must be corrected by putting prism in front of the fixing eye, then deviation measured with the prism cover test while prism located in front of the non-fixing eye, and during that time, first prism stay on the fixing eye. If there is no sufficient vision in the non-fixating eye, Krimsky corneal reflex test preferable for this kind of cases. And same problem, let my turn again, because still stop share and there is something problem. Maybe I continue this types. Is it seen now?
Yes, see now, yes.
Okay. But still don't work. Okay.
Oh, yeah, okay.
Yeah, okay. Esotropia with nystagmus without abnormal head posture, surgical plan, medial rectus recession, lateral rectus resection procedure on affective eye, and tenotomy and reattachment on the other eye. If needed, on all four horizontal recti, use during the operation for the correction of the total deviation. Bilateral recess medial rectus or recess and faden medial rectus for the total deviation can be used if deviation in only at near. Bilateral recess medial rectus for the total deviation plus tenotomy and reattachment on the remaining two horizontal recti, another good choice. Exotropia with nystagmus without abnormal head posture, lateral rectus recession, medial rectus resection procedure on affected eye on the and tenotomy and reattachment on the other eye if needed on all four horizontal recti for total deviation can be used, and bilateral recess lateral rectus for the total deviation in only at near, and bilateral recession lateral rectus for the deviation plus tenotomy and reattachment on the remaining 2 horizontal recti is another good choice for this. I show several cases from my clinic, pre and post-operative deviations, not nystagmus. And if patients has esotropia with nystagmus and face turn for null point operation plan change according to their fixating eye. Face turn up ipsilateral no fix to fixating eye. Medial rectus recession, lateral rectus resection up to 10 millimeter on fixating eye. This operation affect both head turn and esotropia. Medial rectus recession and lateral rectus resection procedure for non-fixating eye if necessary because of the very large esotropia. And the face turn ipsilateral to non-fixating eye, medial rectus recess, lateral rectus resect procedure on fixing eye for head turn, and medial rectus recess, lateral rectus resect on deviated eye for deviation. In this condition, because of the first operation, get esotropia is a larger amount of the deviation, the non-fixating eye operation needs more application. Nystagmus blockage or convergence dampening syndrome also esotropia groups, and in this condition, bilateral medial rectus recession and lateral rectus resection can be used. Bilateral medial rectus Faden operation also a way. Bilateral medial rectus recession and Faden operation another choice, and bilateral medial rectus 3 millimeter recession and bilateral lateral rectus tenotomy and reattachment another choice for them. And when I perform the operation, I prefer according to their deviation amount. Face turn with exotropia operations also be planned according to fixing eyesight. Face turn ipsilateral to fixing eye, medial rectus recess, lateral rectus resect on fixing eye for head turn, and lateral rectus resect, medial rectus resect procedure for deviation. Face turn ipsilateral to non-fixating eye, lateral rectus recess, medial rectus resect procedure on fixing eye affect both head turn and exotropia. Lateral rectus recess, medial rectus resect on deviated eye if necessary. Of course, sometimes the first operation enough for the exodeviation. In this condition, we can perform non-fixating eye only tenotomy and reattachment procedure. Chin up head posture and strabismus talk about very nicely previously, and chin down head posture and strabismus solution talked about previously again by the Lionel Cowell very nicely. And I came the multiplanar head posture and strabismus surgical planning have another difficulties. The muscle each eye combine respective oblique procedure plus vertical recti for chin up down with 9-10 millimeter, recess of lateral rectus of abducting eye, and 7 to 8 millimeter recess of medial rectus of adducting eye for face turn can be performed. Recess or resect one horizontal rectus on each eye for strabismus with no face turn is another choice for that kind of patients. Using foremuscle excessive recession in strabismus used very largely previously, but even detachment of the muscle and reattachment give us very good results for decrease of the amplitude and the increase of the fovation time. And in late acquired nystagmus, foremuscle excessive recession has noticeable improvement in both visual acuity and decreasing amplitude. In the past, I performed this operation in several strabismus cases. When I planned the operation, I used the calculation as planned resection in proper muscle performed as minus from original resection. For example, portive prism diopter ET plan is lateral rectus resection for both eyes only 2 millimeters, and medial rectus resections are 10 millimeter. Theoretically, it performed 10 millimeter resection for both lateral rectus, but the results are not successful in some of the patients because in normal strabismus operation, the calculation scales are shaped according to the standard operations and not for the muscle retroequatorial placement. This operation resulted unexpected globe protrusion in especially young adult and in children. And I give you one case from my archive, 24 years old male, best corrected visual acuity, in both eyes 0.2 and binocular distance acuity 0.2 near 0.5, and see another values on the scale. In this case, performed right lateral rectus 10 millimeter resection, right medial rectus 8 millimeter resection, left medial rectus 4 millimeter resection, and left lateral rectus tenotomy and reattachment. 6 months control exam, we saw 10 prism alternate exotropia with best corrected visual acuity, both eyes in 0.2, but binocularly distant 0.3 and near 0.8. And you see very early videos. And I talk about our treatment protocol in my clinic. Preoperative phases is similar as the old clinics. But when we come to the treatment, first we using brinzolamide eye drop for over 5 years old of age, 3 times of a daily for a week. Then control abnormal head posture, visual acuity, and amplitude of nystagmus. And it's if there is enough progression for the case, we can continue with this. And sometimes we add to use baclofen or gabapentin medication for 3 weeks, then control abnormal head posture, visual acuity, and amplitude of nystagmus again. And then if we plan operation, first we are always stimulate it as Botox injection to the recession plant muscles. And sometimes sometimes the head postures change after Botox injection, or sometimes some values change after Botox injection. In this condition, we change our ideas of the operation. And as a summary of my presentation and take-home message are, operation decision is not easy if patient have strabismus and nystagmus together. Preoperative evaluation and preparation are the keys of the postoperative long-term success. Step surgery can be preferred in very complicated cases. In small deviation, for horizontal muscle disinsertion and reattachment may be enough for correction. Pay attention for anterior segment ischemia. Operation decrease in nystagmus amplitude, but not eliminate it. And as a summary of my presentation, and I have special thanks for von Norden, Dr. Campos, Dr. Kurana, Dr. Hertel, and Dr. Deloso for their very valuable books for guidance for us. And Dr. Annette Spielman for her valuable speech in ACA meeting. Their guidance in my practice, and big thanks for audience for their kind attention, for everybody for their kind attention for my presentation. Thanks again.
Thank you, Dr. Birsen, for a very excellent plan, because nystagmus with the strabismus is difficult to measure. Strabismus itself is very difficult to measure. So, Dr. Birsen, can you tell us some points how to measure strabismus when the patient has nystagmus? Because sometimes it is difficult to measure the strabismus if the patient has coexisting either a vertical nystagmus or a horizontal bit nystagmus. Any tips and tricks for the audience?
Okay. If the patients have vertical head posture, I plan to first to put the eyes on the primary position, and then I perform that kind of patients step operation. As the audience must know, in Turkey, the patient's health service is free from charge in government hospital. And I worked in government hospital. And I need to give some numbers of you. I check my list in the year 2018 to 2009, only 1 year, we performed 1,840 application in our hospital. In only 75 for nystagmus cases. And we performed 32 operations for them. And I performed 15 abnormal head posture and 4 multiplanar. It's not very often multiplanar nystagmus, and 6 for nystagmus blockage syndrome, and 11 without head posture. And in especially multiplanar cases, I perform first Botox for their head posture to get horizontal normal plan. And then I measure their deviation amount, and I perform the operation after that. If there's a small amount deviation, I perform each eye one muscle. And if there's a very large deviation, sometimes I add augmentations types of the operations. And previous conversation, I put notes. I like to plication, but in nystagmus cases, tenotomy and reattachment very important. Because of this reason, in that cases, I prefer vessel protecting procedure and the tenotomy and resect behind of the vessels and reattach that. And I try to explain in multiplanar strabismus with nystagmus needs specific observation. And in our clinic, we observe the patients least 3 times, least 10 minutes, because their head posture and the size of their deviation changeable. And we perform first 2 muscle, maybe 4 muscle totally in 2 eyes, and then observe again. And if they need additional operation, we perform after that.
Okay. Thank you, Dr.
Thank you for your
Birsen.
question.
Thanks for the nice talk. I will invite Dr. One of our fellows to present a case, straightforward case.
Before I start, I would like to thank Dr. Shashikant Sethi sir for giving me this opportunity to present in front of all esteemed mentors. So here it is.
An 11-year-old male came to us with the complaint of involuntary movement of both the eyes, which was associated with defective vision since birth. He had a chin elevation, which was noticed by his teacher in school, for which he was punished, thinking he had a bad attitude. Didn't have any history of photophobia or nyctalopia. He was born out of non-contiguous marriage, and he had a younger sibling of a 3-year-old female child who had no similar complaint. He was born out of full-term pregnancy, and his birth weight was 3 kg. There is no any significant perinatal history, and there is no developmental delay. On external examination, he had a quite dynamic head posture, having chin elevation of 20 degree, alternating face turn of 10 degree, and height tilt to the right side less than 10 degree, which was measured with the chrome. When we measure visual acuity, his unaided visual acuity monocularly in both the eye was 20/200, and its best corrected visual acuity, both the eye, was 20/80. His right eye myopic correction was 2.5 diopter and left eye myopic correction was 3 diopter. His binocular visual acuity was improved to 20/60, which corresponds to 0.5 logma. We measured 9 gaze visual acuity. It showed 0.3 logma acuity in down gaze, 0.5 logma in primary position and dextroversion, and 0.6 in elevation, dextro elevation. And in levo version, it was 0.8. On orthoptic evaluation, he was orthotropic in primary position. On Worthford dot test, he had binocular single vision both for near and distance. His stereopsis was 1/22 of R, which was measured on TNO chart. His near point of accommodation was 8 cm. His anterior segment findings were unremarkable. There is no any translamination defect. On fundus evaluation, his both eyes showed normal optic disc with cup disc ratio showing 0.3:1 with normal vessel and normal background. His both eye having crisp foveal light reflex. We observed the child for continuously 10 minutes and we noticed that he had bilateral, horizontal, jerky, aperiodic alternating nystagmus, which was dampened on convergence. He had a null zone in down gaze and there is no any latent component. We did eye movement recording and fovation analysis showed fovation duration of 24.8 milliseconds. His Netflix was toward the lower side of 0.08 because we did eye movement recording without glasses. His knock was -1.36. So based on this clinical finding and history, we put the diagnosis of aperiodic alternating nystagmus with abnormal head posture. And we did bilateral symmetrical inferior rectus recession of 5 mm with bilateral superior oblique posterior tooth tenotomy. On 1 month post-op, the child had 10-degree chin elevation and alternating face turn of 10 degree. His nystagmus amplitude was quietly reduced. His eye movements were full. There is no any limitation of restriction. On post-op eye movement recording, his fovation duration is increased to 33 milliseconds. Netflix also increased to 0.22 and knock was toward the negative side of -1.6. So to summarize this case, preoperatively the child has binocular visual acuity of 0.5 logma, which was improved to 0.2 logma, and there is no any torsional diplopia. Child has 20-degree chin elevation, which was improved to 10-degree chin elevation, and his Netflix and fovation duration also improved postoperatively. So I would like to ask to the panelists, which surgery you will prefer for this case, vertical recti recession resection or combined vertical rectus and oblique surgery or vertical tenotomy and reattachment? And other is what is the average rate of superior oblique paresis and any developing patterns after this surgery in your experience?
Well, seeing I talked about tips, I'll talk about tips. Dr. Shetty did surgery that's very sensible, was very successful. The one thing I do is always check for a convergence null for distance before you do the surgery. If he has a convergence null for distance, I would do a BMR. If he has a convergence null for distance and still has a tip before a tip despite wearing prisms, I would do BMR and the vertical surgeries that you did. And you've had a great result.
Dr. Maria, what is your basic surgery for vertical head postures? How you go?
Well, also with Dr. Cowell, I would do, and what you've done, inferior rectus recessions, plus or minus superior oblique posterior tenotomies. In some children, I've done just inferior rectus recessions. It's a little less concerned about torsion, but in older torsion adults, will do what you've done, a very similar surgical management plan.
And if he still has a residual chin up, what is your next plan of action, Dr. Maria?
It depends on because it depends on how problematic the residual head posture is. So whether I would do possibly a further inferior rectus recession. I know some people do inferior rectus recession, superior rectus resection, but I think you did 5 millimeters, so you could do a little bit more recession. Sometimes if I'm doing large recessions, I'll do on using tutoplast rather than just recess, as I do in adult strabismus patients if I'm doing large inferior rectus recessions. But that's probably what I would do if needed, because I think you've had a good surgical outcome. He's left with a 10-degree chin elevation, so I wouldn't necessarily do more surgery just for the sake of it, if it seems like a good surgical outcome to me.
Can you try vertical prisms for these patients?
Have used vertical prisms occasionally. Yeah, I don't use them routinely, but I have used them. I do use them sometimes. I tend to use them more as a preoperative, for small angles and as preoperative assessment. The children don't seem to tolerate them as well. They don't seem to like prism trials or prisms as long-term treatment. I don't know what others have found, but I tend to use it as a preoperative assessment rather than as a long-term treatment mostly.
Dr. Birsen, what is your mode of management?
The patients already wear the glass, and the prisms is not get difficulties for this patient. And 10 prism is possible to add his glasses, and it's very easy to solve the problem without any other operation. And maybe you may try inferior rectus Botox if the head posture is gets better. If it's work good, it's very the result is very nice for you. Maybe you can repeat the Botox, or you can add the superior rectus operation. But the glass and the prisms is very easy and good choice for this case, special for this case.
Dr. Serafino, what is your take on this type of cases?
Yes, thank you, Shetty. I always check for that convergence near them, and I do what Lionel Cowell does. But if I have to do surgery on vertical, like in this case, I like the inferior rectus recession of 5 millimeters, like you, and adding the superior oblique tenectomy. I learned this technique by Richard Ertl, and he he takes away all the tendon between the nasal border of superior rectus and up to the place where the tendon goes to the tenon, capsule. So all the tendon. And what I can say is that I don't have, the down gates, movement is the same across all the gates. I prefer this technique, and also in case of chin down, tip down, I prefer superior rectus recession and inferior oblique anterior transposition. I don't like adding resection of the other muscles because I'm a little bit worried about the possibility of a pattern after surgery, V pattern or A pattern, depending on which muscle you operate. So I prefer to do the recession associated to surgery on oblique muscles, superior or inferior, depend on the tip.
Suppose this patient had 40 degrees of chin elevation with a head tilt to the right or to the left with a face turn, then how you would have managed this patient?
Well, if we mean tip elevation and head
tip
tilt?
elevation, yeah, tip elevation of 40 degrees.
I understand. I always operate the most relevant anomalous head posture. So degrees of elevation with a recession of 5 millimeters. I don't like to do 8 millimeters and tonectomy. I do 5 millimeters and superior tonectomy. I don't want him to impair too much the down gaze.
But that will not correct so much amount of head tip up. No? It may correct up to 20 degree. It will correct up to 20 degree of tip up. If he has 40 degree of tip up, then how will you manage these patients?
If there remains a lot of tip up, I'm obliged to do superior rectus. Working to the superior rectus and do resection, of course. And there is no other choice to me.
If there is a head tilt combined with it, then do you correct the head tilt for the head tilt also?
Yeah. If the head tilt is relevant, yes, I try to do that with the movement of the horizontal of the vertical recti.
Okay.
You can transpose of 7 millimeters the vertical recti actually in the same direction of the head tilt.
Okay.
There are as Lionel Cowell said during his great presentation, he suggested in his personal best recommendation to read the Losso and Hertel book. In their book, there are a table where they describe 10 different surgery for nystagmus, and they named that surgery number 1, 2, 3, and so on. And one of these is surgery in case of head tilt, and they suggest to move the vertical recti in the direction of head tilt. So if you operate on the patient and you detach the muscle, you move the eye in direction of the head tilt, and then you reattach the muscle. That's easy to do.
So Dr. Cowell, how will you manage if the patient has got a large chin up or chin down with head tilts?
Well, sometime, let's say the patient has a big tip up, I will use very large base up prisms in the office, say 30 diopters, to see if that will fix the tip. And commonly, once the tip is fixed, commonly, but not always, the tilt goes away. Okay. And that tells me that if I fix the tip, I don't need to operate for the tilt. And that's now, once you get up to 30 base up in each eye, you're starting to get a lot of artifact. And the office findings are not always that reliable. 20, 25 of prism front of each eye, I think you get fairly reliable results. And I do the same with multiplanar tilt. With multiplanar, if someone has a face turn and a tilt, or a face turn and a tip, I will often correct just one component with Prism in the office. So if a child has a large face turn to the right, I'll face turn to the right. It's, for me, it's 1 o'clock in the morning. I'm not thinking straight. Child has a large face turn to the right, I will use large base right prisms, 25, 30 diopters over both eyes, to see if that will not only fix the face turn, which it will, or not fix it, it'll dramatically improve it, but if that fixes the vertical or the oblique, then I know that I don't need to operate on the vertical or the oblique, or on the contrary, that I do need to operate. So this is how I would approach a patient with, I think the question you asked was
with the chin, with the head change.
The paper that that Max was referring to, this is now a very old paper. The authors were von Norden, Rosenbaum, and Kushner. Is that right?
Yes.
And that was 25, 30 years ago now. And I have found that approach useful, but not for big tilts. It's useful for small tilts. For big tilts, I think you have to do oblique surgery. And I usually ask Dr. Sousa Diaz for advice on what to do, because he has a big experience, and I just follow his recipe.
And Dr. Cowell, you have any this thing, like if the patient has got a right face turn and you keep 25 prisms in his right eye and 25 prisms in his left eye, and the head becomes straight, then what is your surgical plan? That depends on the head posture, or it depends on the amount of prisms what you have kept on his eyes? You have to unmute Dr.
Unmute, Ryan.
Unmute Dr. Cowell.
The prisms measure something different to the protractor. So if I'm using a protractor or goniometer and it measures 25 degrees, the head is the center of rotation, the middle of the head. If I'm using prisms, the center of the eye is the center of rotation. I'm measuring similar but different things. So if I'm going to be using my prism measurements to guide the dose of strabismus surgery, that's okay. And if I'm going to be using a protractor and Hertel's tables to guide my strabismus surgery, to guide how much strabismus surgery I do for the face turn, that's okay. The results are good, whichever approach you use, but they're not the same.
And for measuring strabismus, that by Dr. Sheeman, what is written in his book, to measure strabismus in patients with nystagmus, he says you need to need to see the Bruckner's test and look for the light reflex in both the eyes, and then you keep the prism and you try to neutralize the Bruckner's, the red reflex between both the eyes, and that measures the amount of strabismus. Is that what you follow in your clinic to measure strabismus in patients with nystagmus?
You're introducing now further new artifact of measurement. And you're going
this
to
is
use,
what Dr. Sheeman mentions in his book.
If you're going to use Bruckner at arm's length, if you're going to use a torch at arm's length, you're now measuring at a different distance to what everyone else measures.
Yes.
and you're going to have a new set of measurements with that don't have reliable surgical guidelines. So it would be, it's all an interesting new approach, an interesting approach, but you can't use one set of guidelines in a different set of circumstances. So I do everything according to Hertel, or do everything according to Ringel and Anderson, or to Kestenbaum. Things haven't changed much. But don't mix things up. You know, there's.
This was actually mentioned by Dr. Sheeman in his book on binocular vision disorders.
Uh-huh. But it's something. It's a new measurement.
Okay. Dr. Maria, Dr. Serafino, Dr. Birsen, you want to add something? Or Dr. Spielman?
No, I always agree with Lionel. I can't say more.
I always look to Alain's mother for advice. She was very generous teacher. And the paper that she wrote, the Phil Knapp lecture for APOS, it must be about 25 years ago, Alain?
I don't know.
Oh.
in the 90s, probably in the 90s.
It was an astonishing lecture that I still give to all my fellows when they when we start talking about nystagmus. It's sort of how to differentiate between what we now call fusion maldevelopment nystagmus and infantile nystagmus, and how important it is to differentiate between them.
Yeah, I just wanted to say, in difficult cases, you have to do the simplest, because the simpler the better.
Better, yes.
Yeah, first advice.
Yes.
And then about mixed recession of the inferior rectus and superior oblique muscles. It's not technically challenging to recess a superior oblique, but when you have to do it symmetrically on the right, it's easy because you have to dissect exactly the same way. You have to put the anterior fibers at this exactly the same place and the posterior fibers exactly the same place, just not to induce vertical deviation. And always easy. It's easiest to recess symmetrically the inferior rectus than to do it symmetrically on the other. The only difficult point I would like to share about this.
Thank you.
Yeah, this is an important things that Alain told, because I mean it's months ago I used to treat the A pattern. I mean, this is not nystagmus, but I used to treat the A pattern with a 7/8 posterior tenectomy to avoid to touch the torsion. But I was a little bit worried about the symmetry. I mean, because sometimes it's not easy to do a 7/8 bilateral 7/8 posterior tenectomy exactly the same, because you have to leave 1/8. So, I mean, it's not easy. So now I do an elongation of the superior oblique tendon that is easier to manage to do symmetrically. But I don't do the 7/8 for the reason that Alain just explained very well. This is very important to say.
Dr. Birsen, you want to add something?
I agree with Ellen, because the simplest is the very good result. You can first perform the simple application and then observe the results in a couple of months. The life is very long for them.
Yes.
And then new findings can guide to your new application. And sometimes some patients can heal only one operation or only one injection, but sometimes they need the 2, 3, 4, 5, 6 operations. And but especially in the head tilt, sometimes it's very good results to change the muscles sliding on the nasally, temporally, or vertical muscles, horizontal transportation. There's too many ways, and you need to observe, exam very carefully, and then make a decision and perform step by step in my way.
There is also an old song of Tina Turner, Simply the Best. So, you know, Alain, there is also some musical that it was maybe 20 years ago.
Yeah. You can hear music in the operating room. It makes you relax.
I will do that. I will listen to this music next time.
I will remaining to Lionel for ANET conference during the ACA for 25 years ago in England, and I think it's on the not in London but another university. You remember that? It was very nice conference.
Okay.
Uh,
I think
Cambridge conference.
you're referring to Harrogate. Do you remember Harrogate? I think it's the one, but doesn't matter. I think. Look, everyone, please excuse me. For me, it's after 1:30 in the morning.
yes,
Yes,
we'll
yes,
also,
we'll-
yes, yes.
So
Yeah.
I think we've lastly exceeded our time. So with this, we come to the end of the Nystagmus Decoded series. I'm very sorry we had a lot of issues with the internet today, and I thank all the panelists and the viewers for their time and managing to attend these series. I hope the lectures made Nystagmus a bit simpler and more approachable. So until we come up with next set, stay safe and take care. Goodbye.
Good night. Thank you, Dr. Cowell, Dr. Birson, Dr. Serafino, Dr. Maria, Dr. Spielman, for taking out your time and coming for this webinar.
Thank you
Thank
for
you.
your
Thank
Good
you.
night. Good
Bye,
afternoon.
everyone. Bye, everyone. Thank you.
Good
Thank
evening.
you.
Take care. Be safe.